Primarily a neurologist.
Right?
I am a neurologist, so my knowledge of bone metabolism is very limited. But there was a concern that bisphosphonates, with bisphosphonates, the calcium deposition that takes place in the bone, it is not similar to the natural bone microstructure. And that sometimes makes the bone more fragile. Though there is enough calcium, like it is in Paget's disease, the calcium deposition is happening, but the tensile strength of the bone is not as much as it would be with normal deposition of calcium. So is it correct? First, my question, first part of the question is, am I right on that? Because there was some study in Singapore, there was case reports from Singapore few years ago where they said that the patients were on bisphosphonates and there were spontaneous fractures. Now, following which there was a concern, this concern was raised. So has that been substantiated? And if yes, then is there any wisdom in giving drug holidays while the patient is on bisphosphonates?
Okay, that's a good question, and there's several bits to it. First of all, do bisphosphonates cause calcium deposition in exactly the same way as normal bone deposition in children? And the answer is no, there are differences. So there's differences in how the periosteum, and whether it's laid down in the endosteum or the periosteum. So there are some differences, but the randomized controlled trials of bisphosphonates, which now run to tens of thousands of people, show that these drugs reduce fracture in postmenopausal women. Very few studies in men. So although the bone deposition may not be exactly the same as it would be in natural childhood and adolescence, it still seems to confer advantages to the patient. So that's the first bit. Second bit is the bisphosphonates basically stop bone remodeling. Bone remodeling, all our bones are remodeling all the time. There's meant to be little areas of microfracture and microdamage happening, and your osteoclasts eat out that area and your osteoblasts rebuild it. So that this is a way of repairing bone. And the concern is, if you stop remodeling for long enough, will all these little microfractures start to join up, and you actually end up having spontaneous or atypical fractures. And that is a real concern, and there's no data that happens in under 5 years. No one's managed to find that. But there is data, and most of it is people who've been on bisphosphonates for 12, 13, 14 years who are having strange fractures, spontaneous fractures, or ones that are way below, almost mid-shaft, subtrochanteric fractures. And that obviously is a concern, and the belief is that may have been due to the loss of bone modeling. So 10 years ago we were saying you can carry on with your bisphosphonates ad nauseam. Most countries, certainly UK, US and Australia, have all now adopted a model of saying have it for 5 or 10 years. My own protocol in Edinburgh is that we basically give it for 5 years, we scan people again. If they still have significant osteoporosis, we give it for 5 years further, but we stop at 10 years and give them a period off to allow their bones to remodel, and then we would tend to see them perhaps 2 or 3 years later, or if they sustain another fracture, we would probably introduce the drugs earlier. It's a bit like, I mean, this is a chronic disease. If I see somebody in their 50s who has osteoporosis, their life expectancy is probably similar to other women. But so life expectancy in the UK, 80. I'm seeing her at 50. I will need to try and work out how to manage her bones for 30 years. Or not me, it'll be someone else by then. But essentially, you know, it's how do you manage that? And we are discovering new agents. There are 2 or 3 very interesting new agents on being, you know, at phase 2, phase 3 studies. We're learning more and more about the messenger system in bone, and I'm sure other agents will be available. So bisphosphonates are good. They are effective. There was actually a major report from the ASBMR, which is the main bone mineral research sort of world congress, and they reckoned that basically for every 100 fractures prevented, there might be 1 or 2 of these atypical fractures. So that the benefit vastly outweighed the disadvantages. And you can reduce the disadvantages by reducing or preventing prolonged treatment. Okay.
Only one person.
Yes.
I'm developing a little stoop in my back. I was advised to take this biphosphonate and all that.
Yep.
Is it absolutely essential? There's no sign or symptom of pain or anything, but the diagnosis is that there's a collapse of the vertebra. Should I definitely go for biphosphonate, or calcium and D would be enough?
Well, first of all, I mean, it's quite a lot of people who develop a stoop in older age do not have fractures. That we quite often see people where it's basically muscular and postural. So first of all, if you haven't had fractures, then you don't need to take anything. So a plain X-ray of your back to actually find out if you have collapsed vertebrae may be the first thing. Your fractures that you've already described for us aren't low trauma fractures. If you get hit by a motorbike, that's not low trauma. I think you would, in the UK, at your age, because you've been kind enough to tell us, it would be, I think if you have vertebral fractures, it would be highly likely that you have osteoporosis. A DEXA scan could confirm it, but with the balance of risk would be that you are highly likely to have the condition. Calcium and vitamin D is unlikely to prevent further fractures, but a once-a-week bisphosphonate has about 70 to 80% reduction in your risk of further fractures and of becoming more stooped. But I would recommend find out you've got a fracture first. One of the risk factors for asking for a scan is a loss of more than 5 centimeters in height or development of a kyphosis. And it's surprising how many people, when we do a DEXA, there's a machine that gives us a picture of the lateral view. And it's surprising how many people have developed that who have no fractures. And it's just a postural thing developed over years. And there's no point in treating those with bone active treatment because it's not going to do any good.
Thank you.
Hello, I'm Makesh, one of the geriatricians here. Just a mute point maybe. So we do repeat DEXAs every year, and people who have been on bisphosphonates who had proven osteoporosis, the DEXA scores wouldn't change. Mm-hmm. It's quite a common occurrence, and I was trying to explain to my physician colleagues because they were trying to tell me the medication was not working.
All right.
I think you touched upon it in your earlier answer. It's just to kind of reinforce that it prevents remodeling and the scores might not change. Your comments on that?
That is always a concern, and it was one of the main reasons why we refuse to DEXA scan people too often, that there's regression to the mean. That if you measure people often enough, that you get small differences and people start thinking they're losing bone or gaining bone. DEXAs are not that accurate. They're accurate within 1 to 2%. So if you've gone up 1%, the DEXA scan might actually suggest you might have lost 1%. And you're much more likely to get a meaningful result after a reasonable length of time. And certainly our own protocol is that we refuse to scan people for 5 years. And that way you tend to prevent the concern about this. And at 5 years, the only reason we'd scan people sooner is if they're on a very active drug like PTH, on the new denosumab we're scanning people sooner, or if you sustained a fracture that we may want to know whether or not you're responding to the bisphosphonate. So if you had another fracture and we DEXA scanned you and you'd lost 2%, I might be feeling that I need to think about another agent in that circumstance. But we did the reports, the big randomized controlled trials, which involved thousands and thousands of patients. They didn't repeat DEXAs. So, what we know is that if you treat thousands of patients with these drugs, you reduce hundreds of fractures. And DEXA scanning is an inexact science, and I would recommend using it sparingly. With that, it's one of the reasons we've moved away from doing annual DEXAs, because we think they tend to provide more questions than answers.
Okay. Thank you, Donald. And if there are no further questions, we will call this very interesting and illuminating session to close. Thank you very much.
Thank you both, Dr. John Davison and Dr. Donald Farquhar, and thank you both, the chairman. I request Dr. John Davison to come on to the dais. We request the chairperson to present Dr. John Davison the certificate. Dr. Donald Farquhar. We request Dr. E.S. Krishnamurthy to hand over the certificates to the chairpersons. Dr. George Thomas. Dr. Abhishek Srivastava.
This is one part at least that 11 of the poster presenters have been waiting for, and I have the results here with me, and it has been a consensus by all the judges, and there's just one prize, but they have recommended a special praise for another paper. The first prize goes to poster number 5, which is the effectiveness of single versus dual task to improve motor and cognitive functions. The author is Ratnamala, Dr. Shashikala, Dr. Ramanujan, and Dr. Gauri from TIMS VHS. Congratulations. And a special recommendation. We are sorry that we could not be giving the prize, but however, we'll try and give you the certificates. Goes to poster number 4, which is prevalence and risk factors of peripheral neuropathy among type 2 diabetic patients in rural areas, a community-based study. The presenters are H. Shankari and Manoj Abraham from Pondicherry Institute of Medical Sciences. Congratulations. And we request both of you all to collect your certificates tomorrow or maybe subsequently. Thanking you.
We are proceeding to the 4th session of today. May we request Dr. Shashikala Kannan of the Institute of Neurological Sciences, VHS Chennai, to come on to the dais, and Dr. Muhammad Ghani, SRM Medical College, Chennai, to come on to the dais. Leah. And Dr. Stanley C. McAdam, CSI Hospital, Bangalore, to chair the session on the topic chronic disease management in the elderly, problems and solutions. Over to the chairman.
Good afternoon, everybody. We come to this interesting session, 2 interesting topics for the day, is stroke and dementia. Stroke is the second leading cause of death, of which 2/3 of which occurs in our developing countries. And it is the single largest cause for hospital bed occupancy amongst the elderly in the neurological wards. So it's of great economic importance and it should be treated as a multidisciplinary subject. And we have an authority on stroke here, Professor V. Natarajan, a small write-up about him. Professor V. Natarajan is DM Neurology, is retired Professor of Neurology, Head Institute of Neurology, Madras Medical College, Chennai. He served the MMC from 1982 to 2010. He is a Commonwealth Medical Fellow in the US for 1 year on stroke and epilepsy.